Thank you. Our next speaker is Dr. Steven Simper. He graduated from the University of Utah Medical School, did his general surgery residency through the U.S. Air Force Medical Center, fellowship in thoracic surgery through Tulane. He was chief of thoracic and vascular surgery at Scott U.S. Air Force Medical Center. Did a fellowship in vascular surgery at Pennsylvania Hospital. Then joined the Ogden Clinic in the 90s. Later he founded the vascular surgery program at Cokeville, Tennessee, and then returned to Salt Lake City in 1999, where he's been with St. Mark's Hospital, chief of surgery there. He does a full spectrum of vascular and general and bariatric surgery, and has an emphasis in minimally invasive techniques, and he'll be talking to us today about bariatric surgery. Dr. Simper.
Thank you very much. It's a real pleasure to be here today. When I was living in Ogden, I always looked forward to the Ogden Surgical. I really think it's one of the premier medical meetings in Utah. So it's a real honor to be here today. And I thought about, why am I invited to speak here today? And part of it is after Joanna and I left Ogden, went to Cookeville, and be honest with you, we missed the mountains. We had very successful practice back there. We missed the mountains. We didn't care for Tennessee that much. We moved back to Salt Lake, and shortly after I had an opportunity to join this group, Rocky Mountain Associated Physicians, and I knew D.K. Miller, I knew Gary Goodman, Chuck Edwards, Sherm Smith, but I didn't really appreciate what this group was until after I joined them. This is the current group. Sherm Smith, see if I can. Myself, Rod McKinley, is that we now make up the group. But for those of you who don't know, Rocky Mountain is actually one of the oldest continuously operating bariatric surgical groups in the nation. We follow the largest group of bariatric patients in the world, and our patient base has now become the base of the largest database for research in bariatric surgery in the world, and is used by researchers all over. Now, I don't say that to brag about it, although I'm proud of being part of that, since I didn't complete that whole database. But just to let you know that we do speak from a position of experience. We may not have all the answers, but we do have considerable experience, and hopefully can be a good resource for people here in Utah. I was asked to talk about, we are a center of excellence both for SRC and Blue Cross Blue Shield, which is kind of an important designation. Bariatrics is trying to lead the way in quality, how to measure quality and let people know appropriate training. I was given the topic, of course, what's new in bariatric surgery. And as I thought about that, I thought I could talk about new technologies and laparoscopic and minimally and all. Well, a lot of stuff changed. What has really changed in the last 10 years is people's attitude about bariatric surgery. And so I entitled my talk today, Changing Paradigms About Bariatric Surgery. Now, this also came about, this kind of struck home when I was looking at some of our marketing data. I was sitting at an office meeting and looked back, and back in 2000, when I actually joined the group out in 2001, only about a quarter of our patients were actually referred by their physicians for bariatric surgery. The most patients were referred by other patients and family members and so forth. And let me tell you, most of those patients didn't talk to their doctors about it. Even though we encouraged them to do so, they were very reluctant to talk to their doctors about it. Now, this is 2009, over half of our patients are actually referred by their physicians for this surgery. And I can tell you almost all these other patients have talked to their physicians and are encouraged by their physicians to seek this form of care. Now, why the change in attitude? Well, you've all seen this probably. This is a common slide from the Centers of Disease Control showing the epidemic of obesity in the United States. If you look back in 1990 in Utah, for instance, less than 10% of patients were obese. Now, we're not talking morbidly obese. We're talking about just a body mass index of 30 or greater. Where now in 2008, and I can tell you now in 2010, it's over 25%. Okay. Now, this isn't a phenomenon in the United States. This is a worldwide phenomenon. I was in Paris presenting a paper in August, and the French Minister of Health talked about obesity in Europe. It's an epidemic in Europe. It's an epidemic in Asia, South America, even in Africa. People are either either starving to death or dying from the disease of obesity. Now, so that's really caused us to rethink this problem. And again, I think the change in paradigm is recognizing that obesity is really a multifactorial disease. It's not a lifestyle choice, okay? I know that when I speak about obesity, it seems like it's a very emotional issue, and it seems like I have about a third of the room that already understands this, so I'm preaching to the choir. A third of the room that already has made up their mind, and they're not going to listen to anything I have to say. But if I can listen to a third of the room that will listen and think about some of these things, then we do well. But again, I think more people are recognizing that this is a multifactorial problem. And it's a combination of things. Environment. We live in a toxic environment. We have excess calories available to us. Corporations spend billions of dollars developing products that will actually encourage people to eat more. We spend billions of dollars marketing to people to get them to eat more, and then we blame them because they do eat more. Some of these chemicals, some of the processes really poison our systems and promote the disease of obesity. You kind of combine that with changes in our diet and exercise. You know, I think about when I was growing up, I rode my bicycle everywhere. My parents didn't worry about that. I don't let my kids do that anymore. It's dangerous to let them ride around Salt Lake City and so forth. Our lifestyles have changed dramatically. And a combination of that. And you combine that with genetics. Now, the human genome is really a genome that helps protect us from famine. We don't have famine. We have excess, okay? Psychology, not just the psychology of industry and others to deal with food and so forth. And again, food is an important part of our culture, but people self-medicate with food, just like they self-medicate with alcohol and other different things. It's a very complex problem. And all of these things feed back to hormones like ghrelin, leptin, adiponectin, glucagon-like polypeptide. Many of these hormones we didn't even know about. And then when they get out of balance, they feed back and promote in a positive feedback mechanism to promote this terrible disease. So again, it truly is a multifactorial problem, and it's a disease. So one of the questions that I'm always asked is, you always talk about genetics, and I think about, I was sitting in our doctor's lounge. We have a really nice doctor's lounge at St. Mark's, and they feed us generously for lunch. I was sitting there with one of our orthopedic surgeons, has his plate is packed full of food, and he's got 2 desserts and 2 sodas, and he's a beanpole, and he's sitting there shoveling food in, and he says, "You don't buy that crap about genetics and obesity, do you?" And actually I do, just looking at the things here. But this is an older study, but it was one of the earlier studies that really drove home. Now this over here, this chart here is really a nomogram looking at that population biologists use to study environment's effect on genetics. And you can use this nomogram to look at the effect of antibiotics on bacteria or different environments on rats and humans and so forth. Anyway, Levine and his group, this is published in Science, looked at genetically similar rats. And what you do is if you're genetically susceptible to the environment, you follow along this line. If you are genetically resistant, you tend to follow this line. Well, they looked at genetically similar rats and put them in what they considered a toxic environment, overfed them. And again, a bunch of the rats followed along the genetically prone, and a bunch followed along the genetically resistant. Well, they repeated this study using the next best thing to laboratory rats, and that's healthy college students, and found exactly the same thing. Okay, they subjected these students to they gave them what they estimated to be 1,000 calories more than their usual basal metabolic needs, restricted their activity, and so forth. And again, the interesting thing was, too, is that those students that followed along the genetically resistance after the completion returned to normal weight very quickly, where those that had gained weight had a very difficult time getting down. Again, genetics really does play a huge role. And in fact, research in the field of obesity has changed now. We understand more why people gain weight. Researchers are now looking at healthy weight individuals and asking, how come you're not obese? And we're trying to learn from them to try to find ways. It is a very complicated problem. Now, another change in paradigm because of that, and I don't want to offend anybody here, is that medical therapy, quite frankly, has limited effectiveness. This is from the Centers of Disease Control. In 1991, they were asked to, by the NIH, to look at this problem, and they did a big meta-analysis looking at hundreds of studies and came up with this report to the NIH. And they stated that less than 5% of patients can lose 10% or more of their weight and keep it off for 2 years or longer based on their findings. Now, that's for our patients that are 100 pounds overweight, that's losing 10 pounds and keeping it off for 2 years or longer. And many of our patients do that and still regain weight. Now, the CDC was asked to revisit this again in 2004, and they said, we're not going to do it because it's a waste of time. We don't see that there's been any change since 1991. Now, let's look at a little more modern data. This is published in the New England Journal of Medicine in 2007. This is from the Swedish obesity study. Now, for those of you who don't know, the Swedish obesity study is actually the longest, largest ongoing obesity study in the world. And if you live in Sweden and you suffer from morbid obesity, you will be registered because they're national health organizations into this study, and you'll be either offered surgery and best medical therapy or best medical therapy alone. And their best medical therapy is pretty intensive. They visit their doctor once a month. They are visited in their home by a dietitian and an exercise physiologist every week. Okay. Now, this is a chart from this, and to go over, this is the surgical part. This isn't really what I'm going to show you. I want you to pay attention to this upper line. This is the control. This is the medical arm. And now this particular chart goes out to 15 years, but the study is now almost 20 years out. And in 20 years, in the Swedish obesity study, less than 1% of patients were able to lose any type of substantial weight. They feel that it's actually successful if they can at least stabilize patients' weight. The truth is, and most people are understanding, is that obesity is a very difficult, recalcitrant disease to treat with medical therapy alone. That doesn't mean you shouldn't try, but you have to recognize that there's only so much that we can do with medical therapy. Now, another change in paradigm is the recognition that obesity surgery actually treats a lot of the metabolic diseases that go along with obesity. Now, what are the metabolic diseases we're talking about? Diabetes, hypertension, high cholesterol, high triglycerides. A lot of people don't think about cancer. Morbid obesity is a major risk factor for cancer if you're talking about breast cancer, colon cancer, esophageal cancer, uterine, ovarian, lymphomas. Patients have an increased risk of anywhere from 2 to 10 times the risk of having those cancers or dying from those cancers if they suffer from obesity. And this is just a short list. Well, this is an old study. I like this slide because it's colorful. It comes out of a study in San Diego looking at gastric bypass patients and the resolution of comorbidities. Now, look at these numbers. This type 2 diabetes, 95% of patients in this study were either in resolution or markedly improved. Hypertension, cardiac function, osteoarthritis, sleep apnea. These are the very high percentages of resolution or significant improvement in these problems. Now, this has been looked at, again, at multiple centers around the United States, Canada, Europe, South America, Asia. And while the numbers may be a little bit different in different centers, they're all in this ballpark, very high. For instance, in our studies, we find that in our gastric bypass patients, about 80 to 90% of our gastric bypass patients resolve their diabetes. Now, 100% of them are improved, but 80 to 90% resolve. In our sleep apnea group, for instance, we find that 90% of our patients on CPAP are able to come off their CPAP. Now, these are pretty remarkable numbers. Now, how does this work? And I know that Dr. Wallen's going to be talking about diabetes, so I'm not going to go into that, but I'm going to use diabetes as an example because it's been studied better, and gastric bypass in the treatment of diabetes because it's been studied better than any of the others. But again, just to review that diabetes is a very difficult problem. As you can see, a large number of patients, mostly type 2 diabetes, again, a huge increase in diabetes because of obesity, and there's actually a big group of kind of underdiagnosed people with diabetes as well. Now, there's a surgeon by the name of Rubino who was working at the Pasteur Institute outside of Paris, and he did these interesting studies trying to figure out how come gastric bypass works. And he took these rats, and I always forget the name of the rats, but they're specially engineered to have type 2 diabetes and be in normal weight. And he did surgery on them, and in one group he bypassed the duodenum. Whoops. They bypassed the duodenum and did a Roux-en-Y and bypassed the duodenum. Now, in his control group, he just brought up the gastrojejunal anastomosis here, but maintained food flow through the duodenum. And when he did this, he actually had a sham group operation where he opens the rats, shakes things around, slows them up. No change, okay? The duodenal bypass rats, the diabetes resolves. It goes away. In the gastrojejunectomy group, they still have diabetes. Now, he did a crossover where he took the rats with a duodenal bypass and converted them to gastrojejunal anastomosis, restoring flow through the duodenum. And the other rats, he converted over to a duodenal bypass. Again, when he bypassed the duodenum, the diabetes resolved, okay? So that we really realize now that the GI tract is our hormonal organ. It really controls our metabolism, and it's really the organ that causes diabetes in a lot of ways. Now, why does this work? Well, it wasn't weight loss. He carefully controlled that these rats did not lose any substantial weight. And this goes along with what we actually see in bariatric surgery. With the lap band surgery, for instance, we don't alter the GI tract at all. And patients do get better with diabetes, but it's a smaller number. It's about 30 to 60% of diabetics go into remission, but it takes 2 to 3 years, and it's strictly a weight loss phenomenon. And if they regain their weight, the diabetes returns. Where with gastric bypass, we see 80 to 90% of our patients go into remission, and they usually do so in the first few days, first few weeks after surgery. And if they do regain their weight after that, while they may develop type 2 diabetes again, they're less likely to. Is it increased incretins? Actually, you can measure increase in incretins in gastric bypass patients. Glucagon-like polypeptide 1 goes up pretty dramatically after gastric bypass surgery. This is also observed in rats. What about insulin resistance? Again, you can measure improvement in insulin resistance in gastric bypass patients very quickly through a variety of mechanisms after surgery, and the same thing seen in rats. There's a lot of research going on in this area right now and making us rethink type 2 diabetes. So does it really make a difference in survival, though? Okay, we're putting these patients through a pretty big surgery and doing all this to make a difference in survival. Well, this is a study, again, published in the same issue of New England Journal of Medicine as that last article. Again, you see a few names that are familiar: Sherm Smith, Chad Halverson, myself. We were consultants on this case. But Ted Adams, a researcher at the university, really did the research, and he took 9,000 of our gastric bypass patients and compared them to an equally matched group of Utahns based on driver's license data and looked at survival. Now, the gastric bypass patients were anywhere between 7 to 14 years out from their gastric bypass surgery, which is a relatively short period of time to be looking at survival advantages for many disease illness. But he found that there was a marked improvement in survival. There was a 40% decreased death rate in the gastric bypass patients compared to the non-gastric bypass. When we broke it down to different disease types, for instance, there's 56% reduction in coronary artery deaths, 92% reduction in deaths due to diabetes, and 60% reduction in deaths due to cancer. In fact, you're less likely to get cancer, but if you got cancer, you're less likely to die of it. So there is clearly a survival advantage. Now, because of all of this interesting and really kind of overpowering information about weight loss surgery, it's caused people to rethink this surgery and change their attitudes about it. Now, this is from the American Diabetic Association. They've amended their standards of care in 2009 to include this statement. This is an exact quote. They now recommend bariatric surgery should be considered for adults with a body mass index, a BMI of greater than 35 kilograms per meter squared, and type 2 diabetes, especially if the diabetes or associated comorbidities are difficult to control with lifestyle and pharmacological therapy. Now, what percent of patients with type 2 diabetes are adequately controlled? And again, Dr. Wallen may discuss that, but it's only a minority, okay? Really, it turns out the weight loss surgery is one of the most effective treatments for diabetes that we have today. I'm going to just spend the last few minutes that I have to talk about the procedures. I think that the procedures are always changing and different things are going on, so the details I don't think are as important, but you should be somewhat familiar with it. But I would like to say that it's apparent that it isn't a one-size-fits-all. We have more than one procedure that we do, and it really isn't one-size-fits-all. And I think when you're referring patients, that you ought to take that into consideration and send your patients to a center that does all of these types of procedures, feels comfortable with them, so that the patient can really have a non-biased decision that can be helped. Unfortunately, we're plagued in bariatric surgery like we are in so many areas of medicine with marketing. If you only have one product, you market them. I think about what marketers do. Marketers basically embellish their good sides, play down their bad sides, and make the competition look bad. And that doesn't matter whether you're marketing pencils, surgical procedures, or tennis shoes. So try to keep that in mind. I think a center that really is proficient in all these procedures is helpful. And bariatric surgery actually lends itself to regionalization, which I know that's a hot and controversial topic, but again, it takes a lot of expertise to get good results. Let's talk about the lap band just briefly. Most of you are familiar with this. It's a semi-rigid celastic band that fits around the stomach, has a balloon on the inside that attaches to some tubing. That tubing attaches to a reservoir that's very much like a portacath that goes on the abdomen. You can adjust that band. This procedure does one thing and one thing only, and it restricts how much people can eat at any one time. It's clearly the simplest and safest operation that we do, but it has problems. It has problems that occur later on. Weight loss is modest. Patients tend to lose somewhere between 30 to 60% of their excess body weight, and it takes about 2 to 3 years to do that. It's a lot slower. Reoperation rates are high. We see about 10 to 15% of patients requiring reoperation for a variety of reasons. And in fact, studies are now coming out of Europe where they're reporting as high as 80 to 90% reoperation rates in 5 to 8 years after surgery. Durability is really not known. It does appear to be safe, and people can lose a lot of weight. But again, we don't know what percent are going to regaining their weight in the long run. But it is removable. You can take the band out, and the stomach will return to normal. And again, we have no U.S. studies, but we are seeing European studies now that are saying that about 1 to 8% of bands are being removed per year that they're in. But it is reversible and safe in that regard. Now, the gastric bypass, again, most of you are familiar with this. It's been around. This is really the gold standard. How we do this is we actually divide the stomach, making this small pouch. I should also note all these procedures I'm talking about are done laparoscopically, which is very helpful. And then you create your roux-y. Now, whoops, I'm doing it again. The food comes down here, the digestive enzymes come down here, they mix right here. And I want you to pay attention. This common limb, in this picture it looks short. It is not short. It is 15 to 20 feet long. And while this operation is advertised as restrictive and malabsorptive, there is very little malabsorption of nutrients with this operation. Same thing with medications and so forth. You, of course, do bypass the duodenum, which is important in iron and calcium absorption, but that can usually be overcome easily with supplementation. The real mechanism here is the restriction in combination with the hormonal changes in the GI tract. Again, it's a gold standard, longest experience, proven durability. Again, despite what you hear, most people can keep most of their weight off the rest of their life, but there is about a 10 to 20% incidence of patients regaining all their weight over a 14, 15-year period. It is one of the best operations for type 2 diabetes because of these hormonal effects that we talk about. Now, another operation that's actually been around for a while, but most of you are not familiar with, is the duodenal switch. And how we do this is we actually amputate the greater curvature of the stomach, removing about 85% of the stomach, doing what's called a sleeve gastrectomy. We then go below the stomach about an inch onto the duodenum and divide it at that point, create our roux limb. The food comes down here, the digestive enzymes come down here, they mix here. You absorb most of your nutrients in this common limb. Again, it looks short, it is. It's 3 feet long. It truly combines restriction and malabsorption. It is our most powerful tool that we have in bariatric surgery today. But it does carry with it the greatest nutritional risk because of that. And so these patients have to be monitored. Now, that risk appears to be very minimal, really, as long as these patients eat right and pay attention or followed appropriately, but they need to be watched. It is very effective. Patients lose, on average, greater than 80% of their excess body weight. Best durability, less than 10% of patients regaining weight at 10 years. But again, they do need vigilant lifetime follow-up because they can develop protein malnutrition or fat-soluble vitamin deficiencies if they're not careful and don't eat properly. Now, the last operation I'm going to talk about is sleeve gastrectomy. I do not consider this standard of care. I consider this experimental, but you're going to encounter this because this has become very popular. We do this procedure, but it's become very popular in Mexico, in Europe, our medical tourism. There are centers around the United States that have really jumped on board here. It's appealing to surgeons because it's easy to do, okay? But it's the first part of the duodenal switch. But duodenal switch, we often do that operation in our biggest, patients with body mass index greater than 60, or high, our biggest or highest risk patients. And that's a pretty scary operation to do in those patients. So surgeons would do the sleeve gastrectomy first, and with that alone, patients would often lose 100 pounds or more. And then you could bring them back in 6 months or a year and do the second portion of the operation in a more safe environment. Well, again, some of those patients said they lost enough. They didn't want to come back. So people started doing it in lower body mass index, like 35, 40, 50 patients, and seemed to be getting very good results. I think this is going to be an important operation for us in the future, but there are unanswered questions. We don't know what the weight regain rate is. We don't know what % of patients are going to do this. Because it is simple, you have a lot of people kind of running out and all of a sudden doing it, and we're seeing an increased complication rate, which is a problem. And finally, how big do you make this sleeve? And there's a lot of controversy. Some people are making it very, very small, which I think is leading to some problems. So there are some unanswered questions to that. But again, patients, we're very much a consumer-driven industry like anybody else. But I think it's very important that we do this in selected patients. I think it truly has a place in our armamentarium, but we really caution patients and physicians to look at it very carefully and understand it before they get involved. So again, I just want to say thank you for having me here today, but in conclusion, our attitudes have changed. Obesity is a multifactorial disease, and medical therapy has limited effectiveness. We need better medical therapy. Obesity surgery does treat metabolic diseases, and survival is improved by bariatric surgery. And again, I thank you for having me here today, and if there's any time left, Harry, I'll open it up for questions. Yes. Sorry, go ahead.
I have a couple of questions. I mean, so it sounds like that it's more than just calorie restriction that helps them lose weight, correct?
There's tremendous, particularly with the gastric bypass, the duodenal switch, and the sleeve gastrectomy, there's hormonal mechanisms. For instance, ghrelin, which is important in appetite, we believe, goes down in those operations. Now, it tends to come up with time, but it doesn't come back to the same vigor that it was before, where with the lap band, unfortunately, and with conventional dieting, and ghrelin goes up, which explains why people are hungry all the time.
And the other question is, what percentage regain their weight?
With gastric bypass, it's about 10 to 15%, somewhere in that range. More current data shows that number is going down, and I think a lot of that has to do with better standardization of the procedure and also better education. We recognize that these are simply tools. They're not the complete solution.
Okay, and just a quick other one. The rat study was pretty much reproduced by what you're telling me, or the statistics of the decrease of diabetes. Now, type 2 diabetes we know has an effect on, obesity has effect on type 2 diabetes. Has there been any studies that show that type 1 diabetics are affected by that duodenal bypass?
Absolutely. Actually, again, many of you treat type 1 diabetics, and what's one of the complications of insulin therapy? Gaining weight. We see, and as they get older and they gain more and more weight, they become more and more insulin resistant and more difficult to control their diabetes. So again, we are seeing more and more type 1 diabetics being referred to us. Now, we don't promise them they're going to come off their insulin, but they are usually better controlled, have much lower doses of insulin. Interestingly enough, in the United States, only a very small percentage of type 2 diabetics are healthy weight or have lower BMIs. But in areas like China and India and South America, we see a much higher percentage of population. They're actually doing research, doing these type of studies in lower BMI patients, showing dramatic improvement in their type 2 diabetics resolution because of these hormonal changes. Again, type 2 diabetes appears to be a disease of the intestinal tract and how it processes calories.
In regards to children or, teenagers, I know that gastric bypass isn't recommended, what suggestions do you have, or are they looking at doing that for younger people?
Actually, I do recommend it, actually. And I'm actually currently working on a project with Doug Barnhart, one of the pediatric surgeons at Primary Children's Hospital. We've had a adolescent bariatric program in our clinic for a number of years, and we're now working to develop that in conjunction with Primary Children's. And actually, Doug and I are looking at possibly, I know this, nobody hit me or scream at me or anything, we're actually looking at possibility of operating on kids as low as 10 years of age. Okay, childhood obesity is huge. And we're seeing these young kids, 10 years old, 8 years old, a 200-pound 10-year-old truly does grow up to be a 400-pound 16-year-old, which grows up to be a diseased and sick 20-year-old with irreversible organ damage by that early age. So when do we intervene? I don't know. The Cincinnati Children's Hospital, I just got back from there, and they have a program where they're doing both sleeve gastrectomy and gastric bypass in adolescents. And we've done gastric bypass in ages from 14 to 18 for quite a number of years, and it is safe to do and is effective to do. And there's a lot of data on adolescents, but it's a controversial area because when you start talking about operating on adolescents and kids, there's a lot of emotions involved, but scientifically it appears to be a good thing because, again, the idea is, well, they'll grow up to be responsible adults and lose weight. No, obesity is a lifetime disease, and that the evidence is that they grow up to be bigger, sicker adults. So you have to be very, very careful with kids and so forth, but I think that's where we're headed.
Primary care, we all have patients who you've identified as key candidates for this procedure who are for some reason hesitant and want to move forward. What do you say to try to assuage their concerns about the procedure and work through that?
Well, there's a lot of reasons why people are reluctant to go this way. I mean, this is pretty drastic stuff, okay? I admit that. But again, most of it's informational. A lot of people, I call it the Hillary Clinton effect. Everybody knows somebody knows somebody's had problems. When they actually get to the truth of what happened, it isn't nearly as bad as they found out. But I think education, and one of the things we try to do, for instance, all of our patients that live within a 200-mile radius of us are required to attend one of our risk and benefits classes, which is really to try to educate them about it. It's not to talk anybody into anything, but to educate them about it so we try to make it a very low-key thing. But I think it's changing attitudes. The other thing is guilt. I mean, they've been told, it's all your fault. All you do, if you just ate less and exercised more, you wouldn't have this problem. It's all your fault. You just have no willpower. You're dumb. You're slovenly. I mean, it's a complex issue, and so they're embarrassed. There's all these factors that need to be overcome. And, unfortunately, most of the time the patients get to us because it's been the straw that broke the camel's back. They're now suffering from bad diabetes. They're having other problems that really push them to get here. And I think the changing attitudes of their primary care physicians have really made a difference in referral because they depend on their primary care to give them good advice. And I think we encourage them to go talk to your primary care. You guys are one of the most important people in their lives as far as helping them. You're the ones that treated their diabetes and so forth. So I think that's the way you come up and get around it. So thank you. We're making headway, slow but sure. Most federal plans cover it. Intermountain Healthcare, by the way, now offers, and they've been the big barrier in the state of Utah, now offers a limited benefit for their employees alone. PHP is looking very seriously at a pilot program. And in fact, one thing I didn't talk about is bariatric surgery actually turns out to be one of the few things we do in medicine that's actually cost effective. That's why the Canadians and almost all national health systems offer it, because it saves them money in the long run.